Cast is now starting. All attendees are in listen-only mode.
Thank you, everyone, for joining our webinar today, Detecting COVID-19 Before a Campus-Wide Outbreak with Sentinel Testing Program. Next slide. Today's webinar is hosted by Dr. Travis Wilkes, Michael Berg, and myself, Troy Ayers. The Q&A session following the presentations will be moderated by Genevieve Randall. I'm Troy Ayers. I'm the Vice President of Sales for our Eurofins Microbiology Division, as well as the Educational Channel Manager for our Safer at Work programs. Next slide, please. Before we begin, I have a few notes about today's webinar. The broadcast is being recorded, and you'll receive this recording as well as a copy of the slides via email within 3 business days. We'll follow the presentations with a live Q&A session during which you can submit your questions to our speakers. To submit your questions, use the GoToWebinar sidebar menu. Select the Questions tab, type in your question, and hit Enter on your keyboard. You can submit questions anytime during the webinar. We'll follow up afterwards with any questions we don't get around to during the Q&A session. Why consider Eurofins as your partner? We are a global leader specializing in testing for clinical, environmental, food, and many other sectors. Our 800 laboratory network across 47 countries is supported by 45,000 employees worldwide, including 80 US sites and 20 of these being dedicated to clinical and environmental testing for the SARS-CoV-2 virus. Our comprehensive and very specialized Safer at Work COVID-19 testing applications can help you limit the negative impact in our schools and workplaces. Next slide. Getting back to work and school is only part of the challenge today. Staying there requires innovation and real-time monitoring of available COVID-19 solutions to ensure that we minimize new waves of infection and limit the spread of the virus. Next. At universities around the world, daily college life has been significantly impacted by COVID-19. Campuses have their own sets of challenges based on local, state, and national regulatory guidance. The attractive features of campus living have now become their most significant challenges. In addition to these new challenges, external activities such as traveling sports teams, having guest lectures, and holiday travel can increase the risk of virus spread exponentially. I'd like to now introduce Michael Berg to explore preventive measures for COVID-19 risk in campus living.
Thank you very much, Troy. So my name is Michael Berg. I'm Technical Director for EMLab P&K, Eurofins EMLab P&K. I wanted to give an overview on our Sentinel program, which entails a number of environmental tests that are designed to be included in a more comprehensive plan and mitigation strategies. So we're going to talk about wastewater testing, worn mask testing, surface testing, air testing, and then also about cooling and some of the applications. Of course, when we think about how we address the issue of the virus spread and disease spread, we need to recognize that we need to go from this state here where we have an increase of the infected people to a decrease, or the R value greater than 1 to smaller than 1. And of course, we're all aware we need policies and procedures in place that help us address that. And the testing can then support how we shape those policies, what we do with our staff, with our students, how we define the practices. So we have the element of a workplace safety, which includes surface, worn mask and air testing, but also monitoring where we look at the infection rate and the individual infections, and of course the clinical testing and also the wastewater testing as a monitoring program comes into play with that. I want to start out and talk about the wastewater testing a little more. So this has really been getting a lot of attention and traction lately, especially because it's a very useful tool that can be used to monitor groups of individuals or buildings. We just lost the slide. Let's see.
It just restarted. It'll be back momentarily.
Thanks.
Sorry, everyone. PowerPoint has crashed. We're restarting right now, and we'll be back to the presentation in just a moment.
Thanks.
All right, carry on. Thank you.
Okay, we're back. Thank you very much. So the advantage of using the wastewater testing lies really in the sensitivity of the test. We can test we can find one infected person in a community of about 1,000 or more persons, which is really kind of surprising and astonishing that there's enough virus in the wastewater stream to be able to detect it. But those are numbers that have been confirmed and also aligned with our own findings in the testing. So if you have let's say a dorm building with 200 or 300 students, for example, it's a good sample size to be able to detect not only symptomatic but also asymptomatic spreaders before it comes to an outbreak, and that's really the strength of this type of testing. So we want to take a look at this a little closer, because I think this is really a valuable tool that we can offer. So wastewater testing, the size of the pool really depends on where the sample is taken, of course. So and we can define that by choosing the sampling sites. So we can take samples in the wastewater stream on the outside of a building that then comprises the residents of the building. We can also potentially combine 2 or 3 buildings of a campus or the whole campus or a city even by testing a wastewater treatment plant. So we have those different options depending on what our question is, what we want to look for, and what we want to monitor. We can choose where the sample is taken and then define the pool that we're looking at. And that really makes it a interesting tool. The wastewater testing actually goes back to earlier this year, so there were results and experiments already reported in February, March 2020, right after the outbreak. Really got traction and became public and moved into Europe and the US. There was one report, for example, in Spain, where different cities tested the wastewater and then detected SARS-CoV-2 in the wastewater stream before the clinical cases really occurred. So we have the wastewater detection shown here that showed up quite a bit earlier. We're talking about a week or 2 before the clinical cases, first clinical cases showed up. And then since then, there have been numerous examples. Quite a few of those have been publicized, and you will find in the newspapers. For example, one of the more commonly referenced one is the outbreak in the University of Arizona. Actually, the avoidance of an outbreak by testing wastewater and then identifying asymptomatic students when the virus was found in wastewater and then clinical testing was conducted. This probably prevented an outbreak at this particular university campus. And in the meantime, there have been reports from other university campuses and also from cities. The testing itself can be used in two ways. One is for the detection, where we assume a baseline of 0, like in a dorm building, for example. You would want to have a baseline of 0 and then follow up with clinical testing with any positive detection. For cities, that's a little different. There we want to look at trending if the overall rates increase or decrease. Here's how we do it. So we have a lab in Horsham, Pennsylvania, that's doing the testing for Eurofins on wastewater. We report it in detected and then also as a semi-quantitative value. So we'll give a, if you're familiar with PCR, you'll recognize that a CT value that's indicative of the amount and can be trended. It doesn't give a concrete number of virus particles, but it's a good number for a trending over time, which is shown here in this graph. For example, if the CT value goes up, that means the concentration goes down, which is what we want to see. If it goes the other way, that means we're trending upwards on the infection rates. I do want to point out one example that we got permission to share. So this is from the Franklin Marshall College in Pennsylvania that implemented a comprehensive COVID-19 plan that we're doing the testing for. They're starting with a response team or port pandemic operation response team that's responsible for the development of the policies. Every student is tested and every staff before operations begin, so they completed the testing. And then they're looking at the external COVID indicators, meaning where are people coming from, what are the external indicators and rates on those for students and for staff. They do have a bi-weekly surveillance testing and student center clinical testing. The policies include a college pledge where every student, every staff member agrees to a certain behavior and policies. And then the last key and one of the important portions was the wastewater testing as a monitoring program to find symptomatic and non-symptomatic spreaders early on. The feedback we're getting is that this has been an excellent tool that is a low cost, in comparison, a low cost tool for monitoring of larger groups. I'm still having, oh, here we go. I was a little too fast. So with that, I want to wrap up the wastewater testing and move on to another Sentinel test. Sorry, this was a little slow. I clicked too far. We do have other Sentinel tests that are outlined at the beginning. For example, the worn mask testing that can be used in workplaces or on college campuses also. It works with disposable masks. So if we have a group of people that are wearing disposable masks, we can collect the masks and then do a test on those worn masks and then potentially identify individuals in a population. I do want to point out it does not replace a clinical test. It's not a clinical test. It's still considered environmental testing, but we do have that option. It's non-invasive and another tool that we can use in our fight against the COVID-19. So the idea here is that we can start out with the worn mask testing. If we do get any hits on the masks, we follow up with clinical testing, and Travis will talk about that in a little bit. And then once we identify if we have infected individuals, we can use other environmental tests such as the surface testing, for example, after disinfection to make sure that remediation has been done accordingly. That leads us to the surface testing. That's another Sentinel test that we offer. So we can take surface swabs and identify surfaces that have SARS-CoV-2 deposited we found that, of course, no surprise that those environments where we do find positives are much more likely to have clinically positive individuals. So this can be used at high touch points to identify SARS-CoV-2 in the environment. The question is, does it work? How long is the virus on the surface? Typically, there have been numerous publications. Viable virus has been detected on surfaces 2 to 3 days. Some reports put that longer. Definitely, the virus itself has been detected after 2 or 3 days. So we have good confidence that we are able to detect virus on surfaces, and we have, in the meantime, also had quite a few positives on the surface testing in our program. Why would we use that? In many cases, when we do cleaning and disinfection, we want to make sure that the program is effective and efficient, so we can go back and take swabs and confirm. It can also be used, as I mentioned earlier, for epidemiology, meaning when we sample those high touch points, we can find potentially asymptomatic or symptomatic spreaders. High touch points are those points where more than one person touches frequently. So we're talking about door handles, then toilet sinks, toilet flush. We're talking about floors, chairs, so anything that more than one person would touch would be a good area to take a swab sample and then have tested. There's not any particular guidance on how many samples we need to take, but of course we need to ask what do we want to use the testing for, and does the answers that we expect, do they make sense in our program? And in many cases, surface testing has been found useful in that respect. The last one I wanted to introduce here is the air testing. That's another Sentinel test that we offer in this panel of environmental testing. Why do we want to test air? Of course, especially lately, the air transmission has been discussed quite a bit in the news. We hear about it. We think it can be airborne. There's good evidence. We're dealing with a respiratory virus. There have been some reports from the original SARS outbreak that this was airborne, so there's a good indication that the COVID-19 virus is also airborne. It has been detected in air samples from the beginning of the outbreak. And of course, it's a non-invasive test that we can use to see if the air that we're in is safe to breathe, and if there's any risk of air transmission. So that's the goal of our air testing program, to provide tests that can help us make an assessment on the air quality. For the air testing, we do need to remember that aerosols are not droplets. So when we talk about droplets, we're talking about the larger particles that settle fairly quickly. We deal with that in our swab surface testing, fomite transmission, or close contact. So those would be droplets that aren't aerosols and not considered air transmission. For aerosols, we talk about those particles that are smaller than 5 micrometers. They're also produced through coughing, sneezing, talking, or just breathing. They can stay longer in the air and travel further. And there has been good evidence that this plays a role in the spread of the disease, the air transmission, not just the droplets. So that's why air testing potentially is another important Sentinel test that we need to pay attention to. What do we expect on air concentrations for SARS-CoV-2? In the meantime, there have been some reports on concentration of SARS-CoV-2 in air. I listed a few here, so anywhere from 18 virus copies per cubic meter to a few thousand copies per cubic meter is what we expect in COVID-19 environments. So this is also where we need to be with our sensitivity on the test, is in that range, 100 to a few thousand, maybe below. How do we do the sampling? There's different devices, and for air testing, we currently offer an air test that uses PTFE filter sampling. That works fairly well. It's a low flow. That's the only disadvantage, that we have to set that up for longer times to get to at least 1,000 liter, better 3,000 to 4,000 liters. And then we can use the same technology that we use for our other Sentinel tests, and for the medical testing, the reverse transcriptase PCR, and then detect virus, and then make a reference to the air concentration. And finally, I do want to mention that we introduced pooling in the environmental sampling. The surface test, the swabs, and the worn mask can now be pooled, meaning we can combine 5 to 10 samples from the surface testing into one extraction and one detection as a composite sample. The same for worn mask testing. This was a request from our clients, because we do think about providing cost-effective solutions that everyone can work with. All the Sentinel tests that we offer come with detailed instructions, sampling kits. So we'll try to make it easy and simple for our clients to just follow instructions, and then use those Sentinel tests. We'll help walk you through. If you have any questions, we'll be available to answer those and make sure that the test application makes sense and that it's feasible to do the tests on site. And with that, I want to finish here with the Sentinel test, and then hand it over to Travis, who will talk about the clinical testing a little bit.
Hi, this is Dr. Travis Wilkes. I am the medical director of the Eurofins Safer at Work program. There we go. So the nice segue from the environmental pool testing into clinical pool testing. So clinical pool testing is basically where we take 5 individual samples and we run them at the same time. And then if that pool of 5 samples is positive, then we're able to go back and look at those 5 samples and then see who within that pool was positive. But what it does is it reduces cost and time and allows mass testing for screening and or surveillance. This is really interesting testing because it can be used both as a sentinel if resources are available, and it can also be used in response to positive sentinels. So if you pick up signal from one of the other sentinels that Michael was just discussing, we can then follow that up with widespread pooled clinical testing, which would be more cost effective, and try to find who are those people who are positive, and it can be a useful tool to prevent an outbreak. It's not very useful in the midst of an outbreak or when you expect a very high prevalence, because then basically what you'd be doing is you'd be running a pool test and then you'd be retesting all the individuals within the pool. So it loses its value in that setting. But either as a sentinel or in response to one of the other sentinels, it can be extremely useful. So now we'll get into some of the science behind outbreaks, which our entire goal is to prevent them, but also if they do happen, to rapidly control them as fast as possible. And so I think the first thing to understand when talking about outbreaks is RT and what RT is. I think there sometimes gets to be some confusion between R0 or R0 and RT. So R0 or R0, depending on how you say it, is the basic reproduction number, which basically shows how potentially how bad can this virus spread. So how many people can one person spread it to potentially? The RT is the reproductive number, which is the number of people that an infected person will infect at a given time, with mitigation strategies in place or different behaviors. And so so that can very easily change. Masks affect the RT, behavioral restrictions affect it, symptom tracking, all these things can affect the reproduction number at that time. And I think that's really, really important to understand, because our goal is to keep that RT as low as possible. And all of the strategies we take are really driven at lowering that RT, because we know we have a terrible virus with COVID-19, and that the R0 value is very high, and usually approximates somewhere in the 6 range. And so what that, you can think about, if one person gives it to 6, and then they give it to 6, and then they give it to, each one of them gives it to 6, it's very easy to see how outbreaks grow. So anytime the value is more than 1, the virus spreads, and if the value is less than 1, the virus spread slows down and eventually stops. So the higher the RT, the greater the likelihood of an outbreak. And then, very important to note, RT can change, and it's changed by all the things that that we do. So hopefully that makes sense. So in thinking about that, when you get into an outbreak, so really the main way to manage an outbreak is with really widespread high frequency testing. And a lot of that depends on resources available locally. But we can offer pretty much every solution for testing to help with this outbreak management. There's an option of using pool testing for individuals that are kind of screened and low risk, to kind of keep costs down. So you can use symptomatic screening and contact tracing and things of that nature to kind of determine who's low risk, and then use pool testing for those people. And then for people who would be considered average or high risk, you could use individual PCR testing or point of care testing, which is largely antigen based testing. And you want to do this at a high frequency, somewhere in the every couple day range. Every day is probably the most ideal, but isn't feasible. But every few days would be good. There's also, in the midst of an outbreak, there's also the option that we can offer for an on-site mobile lab that could do a very high volume of tests with very rapid turnaround time. So I mean, we're talking thousands and thousands of tests with a turnaround time of 24 hours or less. So there's a lot of options here that I don't know if people always know are available, but I do think it's really important that there's an outbreak management plan with any strategy that's taken, because when it appears that there's a signal of an outbreak, you have to move very, very quickly to prevent sort of the exponential growth, especially if local data is showing the RT value to be high. So I think it's important that everyone who's involved in creating outbreak management plans has a sort of a laid out path for widespread high frequency testing. In addition, quarantine and contact tracing become key. We have to keep everyone who's potentially infected away from the community, and then we also need to try to do as much contact tracing as possible, and that way we better understand who to test, how to test, what's the frequency, and we can kind of make the best use of available resources. Sentinel deployment gets very interesting in the midst of an outbreak too, as Michael nicely described all the Sentinels that we have. So you could see really an infinite possibility of how to deploy Sentinels in the midst of an outbreak to help mitigate spread, and that could involve a number of different things depending on on unique environments that we can work out. So it could be testing the air in certain buildings. It could be looking at surfaces. It could be looking at wastewater in certain buildings, and just making sure that that the strategies that are being taken are actually eliminating the virus from places where it can spread, and that essentially the people who should be quarantined are appropriately quarantined. And sometimes if you see signal from that might lead to a change in testing strategy, increased frequency of testing, or expanding sort of risk profiling of people. So a few considerations for what happened, why outbreaks are bad, but particularly bad with COVID-19. We know there's pre-symptomatic viral shedding. And so, aside from Sentinel testing and testing that we definitely want to try to find the people who are pre-symptomatic and shedding virus, and there's emerging studies that are showing this this percentage maybe even higher than what we had thought before. But it really shows the importance of contact tracing. When you do find an exposed person, how do you contact trace and find all of the people who maybe were encountered that person, and quarantine everyone, so that then we can implement testing throughout their quarantine and ensure safety. Symptom tracking is also really useful. I call it mindful identification of minimal symptoms. What I mean by that is if people are symptom tracking on some sort of regular basis, hopefully daily, they may realize, oh, I have had a headache, or I have been coughing more than normal, or sort of low-level symptoms that they may not have noticed as much if they weren't mindful and actively tracking their symptoms. I think that particularly makes sense in when we're talking about young adults, because they are much more likely to have minimal symptoms, and making sure that those minimal symptoms are taken seriously and lead to quarantine and testing is really important. There's also, you have to consider the implications of super spreading. So there's some evidence that suggests that as many as 80% of infections are from 10% of an infected population. I think that's really meaningful, because it really hones in on the fact that we have to find every infected person, and it really shows why we have to cast such a broad net. And one infected person slipping through the testing and not getting identified can really propagate and continue an outbreak for a very long time. And so that's a really important consideration that I think we have to have in the back of our mind whenever we're thinking about these measures that we're taking and making decisions about how to allocate resources. So positive test rate. So I hear people talk about positive test rate a lot, and I want to make sure that everyone understands what a positive test rate really means, and make sure that it gets used correctly. So positive test rates are really best thought of as a marker of testing adequacy, or are enough people being tested? And they help understand spread when combined with other data that estimates outbreak size. And so what I'm trying to get at here is that if you have a high positive test rate, what you have to think about is that you're not having adequate testing, because you are missing all the people who are asymptomatic or pre-symptomatic. You didn't cast a broad enough rate. So you got all the people who were positive, but you also missed a lot of the people because you didn't cast a broad enough net. So you want to have a low positive test rate because you want to be testing so many people at that nobody's falling through the cracks and getting missed. So the World Health Organization has a criteria that's pretty strict for less than a 5% positive test rate to show control of an outbreak. And what they're getting at there is that if you get less than 5%, then you're having such a widespread testing campaign that you will find the people when they become positive. And basically, this demonstrates the need for widespread high-frequency screening for outbreak management and prevention. There's very, very good public health data that's collected now, and you can access it for pretty much any state, and a lot of local public health authorities will post positive test rate data, so you can sort of look at it for what it is in your state, your city, kind of more local information, and then you can sort of see how that's looking, and that can help you better understand sort of the outbreak potential of your area as well, because the higher the positive test rate means you're not having adequate testing, and you're going to be more prone or susceptible to an outbreak. Hopefully that makes sense. One of the challenges with these webinars is not being able to see people and get kind of visual feedback. So getting back to the RT, so the goal of all the efforts is going to be to decrease the RT as much as possible. That is really at the heart of everything that we do and everything that everyone is doing involved in this management. So there was a very nice paper published. Paltiel et al. Showed that screening every 2 days with a test that had 70% sensitivity in combination with risk averting behavior would maintain an RT of less than 2.5. So what that means is every person who got infected would give it to 2.5 people. And they estimate that at that RT value, campuses could remain open and functional. I think that the goal that was a study that was published. I think that the goal is to try to suppress the RT as low as possible. In my mind, hopefully we can use our tools to suppress it far below 2.5. So that's our goal. So using a combination of Sentinel testing, rapid and strategically deployed clinical testing, symptom tracking, contact tracing, and local public health data, we hope to work with campuses of all sizes to minimize RT. And with that, I'll hand it back over until the Q&A.
Okay, thank you very much, Dr. Wilkes. Now I want to take a moment and give you a great example of how Eurofins is supporting health and safety at our various universities. One is a good look at the partnership with Marquette Athletics. Marquette reached out to Eurofins over the summer back in August with some urgent needs for a COVID-19 testing strategy to bring their 380 student athletes back onto campus. Baseline testing began within 5 days of initial communications to begin clearing athletes for return to campus, and since then, we've implemented a weekly testing strategy to keep everything moving in real time. Between the fast turnaround times combined with the most sensitive methods, we've helped Marquette react quickly to quarantining positive individuals, immediately diving into contact tracing for further testing as needed, and to significantly reduce the spread of the disease among its student athlete clusters, as well as that of the competing and visiting teams. Okay, next slide. So let's take a moment and revisit the key takeaways from the presentation today. Frequent testing is critical to controlling and preventing outbreaks. We must maintain a very robust cadence when it comes to testing. By using a variety of different sentinels through the mass testing, environmental surface, wastewater, and air, you will increase the chance of finding these positives early. Ongoing vigilance is key because of the speed at which an outbreak can develop. And the most successful mitigation strategies involve high-level communication, training, policies, and a comprehensive testing approach that includes both clinical and environmental components. For the last bullet, I'd like to switch to the next slide, please. Through Eurofins' Safer at Work COVID-19 testing program, we're in a unique position to offer the comprehensive and innovative solutions that universities and businesses need today, both on the clinical and environmental side, in supporting those needs. One bullet that is missing here is the air testing, but wanted to remind you that that is a key component of our Sentinel program. At this point, I'd like to turn it back to Genevieve Randall to engage in the Q&A session.
All right, thank you. Okay, I'm going to launch a quick poll question before we get to Q&A, and that should appear on your screen now. Okay, and our question for you, our audience, is: do you want a Eurofins representative to reach out to you regarding services discussed in this webinar? This could also be if you want someone to reach out to you regarding training, consulting services, anything that will help you control COVID-19 risk on your campus. I'm going to leave the poll open for about 30 seconds. You can select your answer, and then if you have any questions, submit them through the question feature in your GoToWebinar sidebar menu, and we'll move into Q&A. Okay, I'm going to close the poll and move into our first question. So our first question is, let's see, what is the best use of antigen testing?
So I'll take that.
Do you have any recommendations then on the best use of antigen testing or use cases you can share with us?
Yeah, sorry, I got muted. So antigen testing, I think, has its best role when we are trying to rapidly test a very large group of people. So it's not the ideal test for symptomatic for asymptomatic people or for pre-symptomatic people. It's very good in an outbreak environment when you need to rapidly screen a very large group of people very quickly. But it definitely has limitations in sensitivity compared to PCR testing. And so in in a routine kind of testing algorithm, I think that it'd be better for sensitivity to use pooled PCR testing, the 5-to-1 clinical pool testing, as opposed to antigen testing and reserve antigen testing, more for during a potential outbreak or need for a rapid mass testing program.
All right, thank you. Okay, so our next question is regarding pooled PCR testing. At what point would this approach be appropriate? For instance, what is considered a high prevalence, and what factors would you take into consideration to determine this?
Yeah, so so I mean, it's definitely appropriate to use as a sentinel test when you don't know for kind of ongoing monitoring, or if you have another sentinel that goes positive, and then you want to see, okay, what does our community look like, and get sort of an initial surveillance of the community. So it's 5 tests, 5 people get tested in each pool, and so if you expected 1 person in each pool to be positive, then you would really defeat the use of the test, and so that would be 20%. But if you came close to 20%, then you'd probably want to just use individual testing, just because of the high likelihood of having to go back and retest everybody within each pool. I think that you could use pooled PCR testing and watch feedback from it. And so if you notice that your testing was approaching that rate, you would then want to then go to individual testing, but you'd also know that the rate is the infectivity rate is accelerating in your community, and you really need to take an outbreak kind of approach.
All right, thank you. Okay, our next question, if I have an outbreak on my campus, what's a good first step in controlling spread?
So I think a lot of that depends on what the outbreak plan is. So if you have it depends on how you've set up your outbreak management. If there's not a good outbreak management plan set up for rapidly deployed testing at a widespread testing at a high frequency, then the initial safety plan needs to be based upon quarantine and contact tracing. So you basically want to get everyone away from everyone, and then find who has been around positive people, and that gives you a little bit of time to then get more widespread high frequency testing set up. Even though I definitely think that the better option is to have the outbreak plan set up so that you can rapidly introduce widespread high frequency testing as soon as possible, and therefore sort of minimize the need for everyone to be quarantined.
All right, thank you. Okay, our next question is, what is the suggested recommended sampling frequency for wastewater testing?
Yeah, I can take that. So that really depends on the program. Like Travis was talking about, the first step is to put a program in place and then define what you want to achieve. So a typical sampling frequency would be every other day to maybe twice a week. That's what we're seeing from clients. Of course, the more frequent, the better, right? And of course, the funds play a role. Then how much money can we spend, and how many sites do we sample, etc. But a typical frequency that we see is a few times a week. So we're talking 2 or 3 times a week or so.
All right, thank you. Okay, our next question. What types of considerations go into preparing an outbreak management plan?
That's a very big question.
Maybe some highlights then.
So I think the first thing is sort of understanding your unique campus and population, and so that's the initial thing. Is so looking at, you know, how many dorms do you have? How many people live in each dorm? What is the nature of your dorms? Are they, you know, are they single rooms where two people are in each room? Are they suites? Sort of identifying all the variables, and then looking at the whole population and backing up and saying, okay, what sentinels are going to be the most useful for this population, and what's going to be the easiest to implement, and then saying, okay, so when we get the signal that COVID has popped up somewhere, how do we react to that, and how are we going to respond that's going to make sure that RT stays as low as possible. And I mean, that's going to involve having that setup of how are you going to deploy testing at an individual level, quarantine, and contact trace. And so, I mean, I think that pulling all those three things together have to be done for every plan. But I think that the initial stage is stepping back and looking at the unique campus situation and population.
All right, thank you. Let me find a next question for us. Okay, are these tests applicable to public schools, not just university campuses?
I'm going to say they can be. Travis, if you want to take that.
Yeah, I think everything we're saying can be used really at any type of school environment. You know, I think the focus here was on colleges, but that everything that we're saying can be used at a you know, a college level, the same as really any kind of communal living center. I mean, it's not too much different. College from a nursing home. Communal living is probably, or communal working, schooling. I think that this could apply to everything from a preschool to a high school as well. And it may actually be simpler to implement a lot of this in those environments, just because you may have a single building or just a couple of buildings.
All right, thank you. Okay, that is all of our questions today. I want to thank our audience for joining today's webinar, and thank you to our speakers for your time and your expertise. Thank you.